What is hyperthermia as it relates to the treatment of prostate cancer? Today's conversation is with Dr. Gurdev Parmar, who is a leader in the field of naturopathic and integrative oncology. He's the co-founder and medical director of the largest integrated health care facility in Canada, the Integrated Health Clinics. Dr. Parmar is the founder of the Integrative Oncology Institute and Dean of Academics. He has been in practice since the year 2000. Been licensed in British Columbia of Canada and Washington State in the US. He has been an avid researcher looking at his data, and now he has a research team at his clinic, IHC, to look at his research and start publishing some of the outcomes and prospective trials on what he and his research team has seen in his clinics. Lastly, he's been an author of many books. The Textbook of Naturopathic Oncology, a textbook guide of integrative cancer care, and the Algorithm book. Dr. Parmar recently published the book, Arming the Immune System, The Incredible Power of Natural Immunity and Fever Response. We went through the full spectrum of hyperthermia. For example, in prostate cancer, can you just treat the pelvic area or do you treat the whole body with hyperthermia? What's the technology that's out there? And how hot do you need to get? Do you need to get to the point where you feel feverish? We talk about fever and the healing aspects of having a fever. And we talked about some of the politics as to why isn't hyperthermia widely available everywhere? So enjoy this really unique conversation on, look, it's considered an alternative treatment despite all the research around it, hyperthermia. Is it good? Is it the right thing for you? Does it work? My conversation with Dr. Gurdev Parmar on hyperthermia. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I am your host, Dr. Geo, and it is my goal and intention to help you optimize your prostate health or your health after your prostate is removed, and even how to live better as you get older. Today is a great pleasure to, you know much about him from the intro, Dr. Parmar, who is a colleague, naturopathic colleague, literally one of the best in terms of integrative and naturopathic oncology. Great clinic up in Vancouver, and is, again, my great pleasure to introduce to you Dr. Parmar. Dr. Parmar, Gurdev, thank you so much for being on. You know, I figured that if I hassled you enough, you eventually would say yes. So I guess that approach worked.
I'm honored to be on the show, Dr. Geo. Finally, we got it together.
Yes, sir.
And I'm pleased to be on. I'm sorry I missed you in NYC this past weekend, but glad we get to connect here on the show.
Exactly. But it sounded like you were doing something fun and exciting and interesting. You know, for a while now, Gurdev, and you know, we go by first names here. It's just you and I talking. No one is really listening. For a while now, you've been my go-to person in terms of where I would recommend patients to undergo hyperthermia, and my source of information in terms of educating me on hyperthermia. So I figured let's have that same conversation here in this recording and educate the public. Hyperthermia is a very interesting thing. So you are in Canada, we are in the US. Tricky in the US, maybe you expand maybe the regulations here in the US. I know there's some hyperthermia clinics here. I remember maybe 9 years ago where an expert from Duke University came to give us a grand rounds talk on hyperthermia for prostate cancer. And I said, man, this is it. It's going to be everywhere. We're going to offer it here at NYU. It's going to be offered. It's not the case. I mean, there are modalities that use heat or a source of a modality, a source of energy to produce heat localized in the prostate, but not hyperthermia whole body, and maybe how you practice it and how I thought it would be practiced everywhere. And so that sort of died down. Never seen him, never seen a talk like that again. I said, what's happening here? I know this is helpful. So let's start with this. Let's assume that the audience knows. I mean, we have a very educated audience that they listen to a lot of important, good things, and they listen to this podcast quite a bit. But in terms of overview on hyperthermia, how does it work? Particularly whole body hyperthermia. You could take this in any direction that you'd like.
All right. Well, let's start with this. The term hyperthermia is an umbrella term.
Yeah.
And under that umbrella term, there are numerous modalities. There's, local regional hyperthermia, which is where you're treating a local part or a region of the body. There's, as you mentioned, whole body hyperthermia. And even in the whole body hyperthermia realm, there's mild, moderate, and extreme of it. And that's all stratified dependent on temperature, what temperature you're trying to achieve and what you're trying to do with that temperature. There's intraluminal, there's perfusional, there's all these different forms of hyperthermia. And as you mentioned, there's ablative hyperthermia where you're getting to very high temperatures like radiofrequency ablation and laser therapy and high intensity focused ultrasound. And all of these technologies are all under the umbrella term of hyperthermia. The type of hyperthermia that I practice and use in my practice now since 2010 is local regional hyperthermia using a device that's a German device called the Oncotherm. And it's a capacitive radiofrequency device for deep treatment. And I can explain a little bit more about what a capacitive radiofrequency device means. And so that's Health Canada approved. And just to touch on your question, or why isn't this here? It's not yet FDA approved, and it hasn't been FDA approved after many decades of attempts. And I'm unfamiliar with the reasons why. But
can you pause there for a second? Because to me, the cynic, there's a lot of us, I could be one. Well, the FDA doesn't, is politics, is money, is this. Well, I'm also seeing all these other technologies coming in, right? So, but by the way, it used to be, as you know, that there were very few treatments for prostate cancer. Only prostatectomy, radiation therapy, that's it. Now there's focal treatments. But within focal treatments, there's like 8 treatments within focal treatment. So it can't be that it's only politics and bureaucracy when all these other sources and companies are coming in and being FDA approved. So I wonder what's going on in just general field.
I think the simplest answer I can give you is that it's unfortunate that the big players, GE, Siemens, these sorts of companies haven't gotten into the hyperthermia realm. If they had, we may be in a different position right now. But as it turns out, most of the manufacturers of hyperthermia devices are not massive corporations. And to get a device, a class 3 Canadian term, class 3 medical device, something that can cause side effects on a human being, getting that approved, it's an arduous and expensive process that probably will lead to like $10 to $100 million process. And it requires some backing. And unfortunately, the companies that are in the game haven't been able to push that forward in the US anyways.
Well, thanks for that explanation. And sorry to get on that track. It's okay. I'm super curious about that.
I can tell you, I've been interested in hyperthermia since about 2000. And now here we are, it's 2024, and it really hasn't progressed in North America. So I understand your befuddlement. I'm in there too, Geo.
So thank you for that. And so let's take off where you were giving us a general explanation on the different
umbrella
types.
Term of hyperthermia, and then what we've done.
Yeah.
So the capacitive radiofrequency hyperthermia, basically what that means is there's 2 capacitors or plates, and between those 2 capacitors or plates, radiofrequency is being transmitted from one plate to the other in an alternating field millions of times per second. And that's what's heating the patient. The radiofrequency is 13.56 megahertz, which is a long wave, which gives it the depth of penetration, as opposed to something like microwave, which is very short waves and has a more superficial action. there is a microwave device, which is radiative, meaning it's just being emitted from one source, approved in the US. And that may be what you had a lecture about. I'm not exactly sure which device they were discussing, but I know that device is FDA approved. And the fever range whole body hyperthermia, I know that Joan Bull and her group at MD Anderson, and there's another group out of Roswell Park that have been studying the use of fever range whole body hyperthermia as a chemosensitizing and a radiosensitizing treatment. It's for its immunological benefits, and those studies have been ongoing now for a long time, and I haven't seen that it has progressed beyond that.
As a standalone therapy or combined with other modalities?
Yeah, all those studies are typically done as a combined therapy. So alongside radiotherapy to see what the additive benefit is, or alongside various chemotherapeutic regimens to see what the additive benefit is, what, how to properly time it, what is the optimal timing between a treatment, a chemotherapeutic agent, and then the hyperthermia treatment. That sort of thing is what's been looked at the most. Yeah.
So how high does the temperature go? And so then the patient feels, I keep hearing the terms, there's a feverish type of feeling. So what does that feeling feel like? Is it like, wow, I feel like I have a cold or COVID or something? And how long does that last?
Yeah, good question. Okay, so let's break that answer down into two.
Mm-hmm.
So when we administer local regional hyperthermia with that capacitive radiofrequency device, let's say we're treating a man with prostate cancer and we are treating the pelvis. That treatment is an hour in length. A patient lies comfortably on this treatment table and you don't really feel much of anything, Geo. The two capacitors are separated from the body with cooling. So the bottom, imagine the bottom of the bed that the patient is lying on is a plate or a capacitor. On top of that plate is a water mattress with distilled water, no electrolytes in it. And that water mattress is separating the patient's body from the capacitor, which is very critical because the capacitor would otherwise burn them. And then we put the other capacitor over the target area. So in the case of a prostate cancer patient, over the pelvis, that capacitor has a water bolus on it as well. And that water bolus is there, and the water mattress is there to separate the body, the skin from the capacitors and to cool the surface. Most of our temperature sensors are on the skin or just below the skin. So the patient really just feels a coolness. But inside, deep inside, they will feel warmth, not hot, not burning, but warmth. So most people describe it as the feeling of like a warm, hot water bottle, but inside. But on the skin surface, they're feeling cool, which is a little confusing to the brain. You can imagine why we don't really have temperature sensors deep inside of our bodies.
Exactly. Yeah, exactly.
Yeah. And by the way, we've done 25 to 30,000 of these local regional hyperthermia treatments in our clinic now. We have collected data on every single treatment.
Wow.
We've seen blisters of the skin 10 times in previously radiated tissue, and we've seen subcutaneous fibrosis 5 times, always in men that are too severely obese, on the fat pad overlying their pubic bone. That's where we've seen those 5 cases of fibrosis. Presumably, and all my colleagues around the world, Germany, Europe, Asia, whatever, have noted the same thing. And it's probably because that fat pad is so sensitive to the heat and it becomes fibrotic, which goes away by itself. And both the blisters and the fibrosis are very minor side effects. So that treatment is very easy. The fever range whole body hyperthermia is a different beast altogether. That treatment takes 5 to 6 hours. It takes about an hour to raise the person's body temperature from 36 to 36.5 degrees Celsius. I'm speaking Canadian. And that's where like a normal body temperature is, about 36 to 36.5 degrees Celsius. We want to raise that person's core body temperature measured by a rectal thermometer. That's the only way. We don't care what the temperature is in the mouth or on the skin of the forehead. That is irrelevant. So we're measuring core body temperature. We want to see that core body temperature get in the fever range, which is 38.5 to 40.5 degrees Celsius, which is a natural human fever range.
So that's in translation for the American audience. That's about 104 degrees Fahrenheit. So it goes up to about 104, that is a fever stage.
That's a fever state. And so we are mimicking a natural fever. So I mentioned there's different forms of whole body. We are not using what's called extreme whole body hyperthermia, where the goal is to get to 42 degrees Celsius in the core, which requires general anesthesia because that is entirely
not tolerable.
It's not tolerable. So we don't do that. Our patients are not sedated. Our patients are able to withstand this treatment.
So pause there for a second. I'm just curious. So, 40 degrees Celsius, which is about 104 degrees Fahrenheit, is more better. So is it better, right? So the guys that are doing, look, under anesthesia, because, more degrees is better, higher, better, as long as it's safe. My understanding from speaking to many radiation oncologists, friends and experts and really top people in the field, is that there's a fine line, right? They're trying to get the energy to be more, stronger. At the same time, be careful with if it's too strong. So it's a matter of, do you want strong energy in less time to kill the cancer? Or do you want, a little bit energy that's a little bit weaker, but, 30, 40 treatments? So these are the types of questions and things they're trying to figure out. How does it work here?
Excellent question. So no, more is not better in the conversation of whole body hyperthermia. And most of my mentors who are medical oncologists or radiation oncologists in Europe that use this therapy have abandoned the extreme whole body hyperthermia because they found that more was not better. And most of the doctors that now use whole body hyperthermia are using fever range whole body hyperthermia. And so it takes about an hour to raise the body temperature into the fever range. We maintain the patient in the fever range for 3 hours, ideally, and then it takes about an hour to cool them off. We need to make sure prior to doing that treatment that their hemoglobin is okay, that their platelets are okay, that they don't have an active bleed, that they don't have active untreated metastases in the brain. We have to do an ECG. There's certain things that we have to check to make sure that the patient is fit for that treatment. And during the treatment, an ECG is monitoring the heart the whole time. Blood pressure is being monitored every 15 minutes.
So that's an electrocardiogram.
Correct. That's right. An electrocardiogram.
Most people are going to think of each ECG. Wait a minute. Is that EGCG? Or, wait a minute. You use Korean tea catechins? How does that? Right. No, electrocardiogram.
Electrocardiograms, blood pressure is monitored every 15 minutes. Temperatures being monitored the whole time, of course. Respiration rate, nurses with the patient the whole time. And we're dripping in IV saline to keep the blood pressure stable and IV dextrose to keep the blood sugar stable. And so we've used the same protocol. It's how I was trained in Europe. And we use that same protocol for every single patient. And that treatment, Geo, I want you to know, is very difficult to manage, but I believe is a very important treatment in anybody that has metastatic disease. And in the case of prostate cancer, anybody that has skeletal metastases or widespread nodal metastases, and they're using ADT or whatever, this is one of the treatments that I use in conjunction with therapies like that. And I can describe a little bit as to why.
Hold that thought. We're definitely going to get there. When would you, so the person that would get whole body treatment clearly has metastatic disease outside of the original area. And for a minute here, let's just talk just cancer in general. So they're gonna get whole body treatment. It takes about 5 hours. About 5 hours. They feel, and of course, you're not trying to lower the fever. You're not giving them, Tylenol or anything afterwards. That is the treatment. That is part of the treatment. The fact that they're going to feel a little crappy is part of the treatment. How long do they feel that way for?
Great question. So I should mention, am I able to plug something here, Geo?
Yeah, go ahead. Sure.
So I published a book called Arming the Immune System. It's a very easy read.
And it is an easy read. I have the book. Great book. Thank you. Plug away.
Thank you so much. Yeah. So in the Arming the Immune System book, which is a really simple, easy read, meant for just the layperson to understand what this is all about, it describes how this treatment is given. The feverish feeling is really just during the treatment, and then we cool the patient off after the treatment. This is not a true fever. A true fever would be endogenously produced by the body in response to something like a bacterium or a virus or a infectious agent, or possibly, as you know, early on during cancer, patients are building fevers because their body's trying to stimulate the immune system to fight this illness. But once we cool that patient off, they feel like they've run a marathon. Yes. They shower in the clinic, they get dressed. We recommend that evening they just take it easy, rehydrate, eat light, have a great sleep. And most people do. Most people after that treatment, Geo, when they wake up the next morning, they feel rejuvenated. I've done that treatment myself. I have experienced this treatment myself, and I felt very rejuvenated after this treatment. A lot of my patients that have been heavily pre-treated, really severe fatigue, the vast majority of the patients feel much better after, like the day after a good rest after that treatment than they did prior to the treatment. I think it's good for quality of life as well.
So then so maybe it depends, right? That's always my answer with things, right? It depends. People want answers. Just tell me it depends, right? So how many days of this whole body treatment, roughly on average? Let's say, for argument's sake, they have bone metastasis to the clavicle, the sternum, the pelvic area. So they get whole body treatment. How many days, how many treatments? Is it every other day? How does it work?
Yeah, so the local regional hyperthermia, we typically are doing it, let's say I have a patient come from NYC and they have prostate cancer, and they've just had prostatectomy. And it looks like the prostatectomy was complete. Their margins were clear, no perineural invasion, it looks good. The PSA has come down. Now the patient is done with their therapy. But they just want to, like with radiotherapy, they want to treat the prostate bed, they want to treat the lymph nodes, the field, etc. They come to us probably for 2 weeks, 3 weeks. We treat them 3, 4, 5 times per week with the local regional hyperthermia. And twice during that treatment, 1 week apart, we would do the fever range. So the fever range whole body hyperthermia is not done more than once a week at the most, and not often done more than twice in a cycle of therapy. Let's say a person's had cancer and now they don't want a recurrence. The standard treatment is you do fever range whole body hyperthermias day 1, day 8, Q3, 6, 12 months for a period of time. That's it. And the purpose in that setting is you are trying to reset the immune system by inducing a fever-like response where you're activating the innate and the adaptive immune system.
So there's a maintenance component to it. So let me make sure I get this right. It's 2 examples. So one is local treatment. So they do get local pelvic treatment, and 2 to 3 times. You can kind of rephrase that again if you don't mind. And then eventually they're also going to get whole body treatment once a week for 3 weeks.
Typically 2
weeks.
So So let's put it this way. And I didn't say this yet, Geo. So I'm glad we circled back to this.
Yeah.
So when we do the local regional hyperthermia, the goal is to heat the target tissue above 42.5 degrees Celsius, which is called the Arrhenius line. And I don't know what that is in Fahrenheit. I'm sorry.
You said 42.5.
42 to 42.5.
42, that's above 104. So we're talking 108 perhaps.
I think it is, if memory serves.
So that leads me to believe that if you're treating it locally, you don't get that fever response, of course, because it's not whole body. So then you can actually be a little bit more aggressive.
Correct.
in that area.
Correct.
And so how high can you go? I mean, in this particular example, is higher better?
Okay, so to a point. So we know the Arrhenius line, or the break point of human cancer cells, is about 42.5 degrees Celsius. And we start to injure healthy cells at 55 degrees Celsius. So we never want to get that high. And the maximum temperature achieved by the Oncotherm device is 47 degrees Celsius. So that's, nicely above 42.5, nicely below 55, which is why we've been able to do 25 to 30,000 of these treatments and not really seeing many side effects, because we're not achieving temperatures hot enough to injure healthy cells, healthy tissue. And
Great.
Can I say something, Geo, on this? It's important for your audience to know this. With the local regional hyperthermia given to the pelvic area, hot enough to damage or kill cancer cells, one of the things that local regional hyperthermia does is it produces what are called heat shock proteins. And heat shock proteins will change the cell membrane of the cancer cell. It will make it look different than self. And the innate immune cells, the macrophages and natural killer cells, all those Pac-Man looking cells, are always looking for what is not me. It's the self versus non-self part of the immunosurveillance. And so what we're trying to attempt,
and it needs to recognize that's not me. Not only that it doesn't look like me, the immune cells need to say, yeah, it doesn't look like me, and I recognize it, and I have to do something about it.
Correct. So one of our goals with local regional hyperthermia is to make the cells look different, so the immune system can recognize it through the induction of heat shock proteins on the cell membranes. And then the major reason why we use fever range whole body hyperthermia in conjunction with the local regional hyperthermia is because we know fever range whole body hyperthermia stimulates the production of cytotoxic T cells, the cancer killing memory cells. So that's what we're attempting to do, is we're trying to create a localized heat shock protein effect, making the cancer cells look different, and then at the same time causing fever, stimulating a whole body immune response, including cytotoxic T lymphocytes.
I love it. So how many treatments, we know that the whole body treatment, in the case when somebody just have local, is once a week for 2 weeks. How many local treatments do they have to undergo?
Thank you for watching the Dr. Geo Prostate Podcast. Take a proactive step and improve your health and vitality with the Prolon Fasting Mimicking Diet FMD, a 5-day plant-based program developed by Dr. Walter Longo, designed to mimic the effects of fasting without the challenges. Prolon helps activate autophagy, reduce inflammation, support weight management, and promote overall longevity, all while nourishing your body. As a special thank you, you can access the Prolon kit for just $148. Use the link below to get started. Empower your journey to better health today.
Good question. So this local regional hyperthermia device has been around for 30 years plus. And worldwide, this is approved in over 50 countries of the world. And really, it's not a naturopathic treatment outside of North America. This is not standard of care in Canada. But if you go to most of the Asian countries or European countries, you'll see this kind of treatment being administered in hospital settings, in the radiotherapy departments and things like this. Where we are is that the average amount of treatments for a cycle of therapy is 12 to 18, somewhere between 4 times a week for 3 weeks or 4 times a week for 4 weeks, something like that. In some cases, like when we're treating the brain, for example, we cannot treat the brain more than once every other day. So the maximum amount of treatments we can do for the brain is 3 times per week. And so if they're doing 12 treatments, it takes them 4 weeks to do that. So it depends. But let's say 12 to 18 average amount of treatments for local regional. And during the course of the local regional, maximum of 2 of the full bodies.
Excellent. From your explanation of what actually happens from a physiological perspective, where these heat shock proteins are produced. They make the cell membrane a little bit more vulnerable. Now the innate immune system would say, hey, here's a cancer cell, let's get rid of it. The way my brain would work, I'm into, from my experience, again, only prostate cancer. That's really all I know. To me, the world is just one big prostate and we just live in it. That's just the way I look at life right now. So, right? So the way I'm looking at it is, okay, I'm always thinking multimodal approaches. I think that one approach is just never enough for me, right? Multimodal. What are the different things we could do? Not just one thing, right? So what I do, people come to me, is like, okay, here's prescriptive lifestyle, prescriptive exercise, supplements, diet, sleep, those things. With this approach that you're describing, hyperthermia, to me, I'm like, wait a minute, why not do hyperthermia and then follow up with radiation? Right? Now these cells are sensitive, and now the radiation is probably better to hit it hard and get rid of it. Am I missing something here? Am I oversimplifying?
Absolutely not. I on the note of you should know, if you go do a PubMed search on what is the evidence to support hyperthermia for cancer treatment, the vast majority of the evidence you're going to see is in conjunction with radiotherapy and chemotherapy, for obvious reasons. Mm-hmm. Hard to get a study approved for an alternative treatment, much easier to get a study approved where you're adding a new treatment to the standard of care to see what the differences are. Awesome. On the note of radiotherapy, hyperthermia is a very, very good radiosensitizer for a few reasons. Radiation works on the M and G1 phases of the cell cycle. Hyperthermia acts in the S phase. So now you have 3 different phases of the cell cycle at which you can have cellular damage occurring. Radiotherapy needs
give me an explanation really quickly on what you mean by M and G1 phase and the S phase, really, so that the audience can put it all together.
So cell cycle. So when a cell is going through its process of dividing into a second, or one cell becomes 2 and 2 become 4 and etc. That's the exponential growth phase that we all know about when we're considering cancer. The cell goes through a cycle when it's going through this process of becoming 2 cells. And without getting into the fine details, I don't want to muck it up. Yeah. There are several stages of this cell cycle, and radiotherapy kills cancer cells in 2 of those parts of the cell cycle, the M and the G1, and the hyperthermia is acting in the S phase. So now instead of 2 out of 5 portions of the cell cycle, now 3 out of the 5 portions of the cell cycle, you can injure or damage or impede cell division. Right. I hope that helps.
Yeah, no, I knew it wasn't. You said it way better than I can say it in layman's terms, so I appreciate that.
Yeah, you're welcome. And then here's another thing. Radiotherapy. I think most of your audience probably knows this. Radiotherapy works best in a well oxygenated environment. Yeah. And hyperthermia being heat, radiotherapy can burn, but it's not heat. Hyperthermia, which is heat, creates vasodilation, and which means it opens up the blood vessels. Anybody knows if you put a hot cloth on your skin, it's going to turn pink or red. If you put a hot water bottle anywhere on your skin, it's going to turn pink or red. Why? Because all the blood vessels are opening. It's called vasodilation. And this is to put more blood through the area to cool it. The blood is the coolant. So we know that hyperthermia increases oxygenation of the tissue. And most of the research, and your thought is really, really good, Geo. Most of the research on the benefits of hyperthermia, we don't know yet. Is it best to do the hyperthermia before the radiotherapy? Is it better to do the radiotherapy before the hyperthermia? If they're doing both treatments on the same day, is it better to do one versus the other before the other? We still don't know the answers to these questions definitively. But what I can say to you is this. When I have a man going through prostate radiotherapy 3 times a week during that 5-day-a-week, 6-week protocol, 2 to 3 times per week, I am getting them to come in to do hyperthermia. At least for my local patients who are doing radiotherapy in the Vancouver area or possibly just south of the border in the US. And then they're coming to the treatment to do hyperthermia as a radiosensitizer during the course of the radiotherapy.
Beautiful. How about in cases where, okay, so they already had radiation. So I see all these prostate cancer patients, right? And so some of the ones that I've sent to you are those that they really want to crush it, right? So they're saying, look, I'm getting radiation. What else can I do other than the lifestyle prescriptions that you're providing for me? Like, I'm willing to crush it. Like, even if I get the radiation, there's no sign of recurrence, but just to be, lower the risk of recurrence, what else can I do? There again, not hyperthermia prior to radiation to make these cells most sensitive to the radiation, but after the radiation. So, I mean, I think you answered the question. It kind of does it. We don't know which comes first, would be best, but it sounds reasonable that there might be some synergy there, even, radiation first, then hyperthermia.
And that's how we do it in our practice, Geo. You're exactly right. So, as you know, the effects of radiotherapy last a month. I mean, some of my rad-onc colleagues tell me, truthfully, it's doing it for 2 months or possibly a bit longer. We don't know exactly how long, but let's say the 1 to 2 months post radiotherapy is a window of opportunity to make 1 + 1 = 3.
I love it. You answered a lot of my questions. So where are we with, when we don't know about a particular treatment? I'll give you an example, proton beam radiation, right? People come to me, hey, I saw this commercial. So a lot of it is driven by marketing.
Yes.
And good marketing, because people are talking about it.
Yes.
And it's like, well, they come to me, and there's two types of prostate cancer patients that come to me. One is, can you be my navigator? My trusted source, my quarterback, if you like football. I have this is what I have. What are my real options? I'm confused. So then we kind of break that down. And so then proton beam radiation, I don't recommend a whole lot because I haven't seen many patients that have done it. It's been a while that I've seen a patient that's done it. The patients that I've seen that done it, a few of them have gotten a recurrence. I don't see a lot of data published on it. So then my question is, for those that think like me, is like, okay, I don't know anything about hyperthermia, but where's the data? Where are we with the data? So when I did a PubMed search, and you're right, a lot of it is combined with radiation therapy, but is not, I think the last paper is like, other than overviews, like 2015 or so. Where are we, and why does it take longer? What's the behind the scenes in doing the right study, a good study, and publishing it so that there's more awareness around hyperthermia?
So I can tell you that we have submitted a 10-year retrospective study for publication for colorectal cancer, stage 4 colorectal cancer, most recently, to current oncology. We're just waiting to hear whether it's going to get published. We've submitted a paper for publication for the glioblastoma multiforme.
Brain cancer.
Yeah, brain cancer, same thing. And we have, over the course of years, submitted multiple papers for publication on the topic of hyperthermia, and it's difficult to get published. And one of the reasons why is because we're not doing a prospective randomized controlled trial where we're giving half of the patients this therapy and half of the patients that therapy. We're looking back and saying, this is what we noticed for the patients that added this to their lives. And that's not the best type of data, as you know. Most researchers don't love retrospective type of data. They want prospective data. They want randomized data. They want controlled data. And so we don't have that sort of data. And there is that kind of data, but not so much for the prostate cancer. And why that is, I'm not exactly sure, Geo, why that is. I can say to you that having been in this field for as long as I have, it's frustratingly slow at making ground. And, something I said earlier on in this podcast is, it would be really great if some of the big players got involved in this field and moved the needle. I think that's what it needs. It needs.
So even even at Europe, same issues, right? So even those institutions they're all having the same issues. I mean, for example, I know that in the U.S. to form a study is very expensive because I've done it and I've tried to do it with like dietary supplements. It's like, well, there's no way. So typically a lot of the studies that come for dietary supplements are done outside of the U.S. or maybe Canada because it's just less expensive. But even in those countries, it's still a challenge.
It's still a challenge. I mean, look, there's a journal of clinical hyperthermia. I believe it every 2 months publishes a number of papers. There's organizations called like ESHO, the European Society of Hyperthermia and Oncology, that do annual conferences, have for decades, literally hundreds of attendees from around the world. But if you're not in the field, you don't see it. And it's just not getting airtime. It's not sexy.
Essentially, hyperthermia needs better marketing.
It needs, you know what it needs, Geo? It needs some dough. It needs like a player. It needs a player in the game that is in it and knows it and knows how to do it.
Right.
That's what it needs.
Yep. I see it. I see it. So thank you for, I mean, that was a very, I feel like I've learned so much from this. I knew that, I know I would, right? I knew I would learn so much from this things that I didn't know prior to. The last thing I'll say is this, is a comment and perhaps a question. Most drugs are used with a different intent than it was originally, it was supposed to be used for. In other words, it's used what is called off-label. Out-of-the-box thinking, particularly as it relates to cancer, I think is a very reasonable approach. You have to, because no one person, no one institution has all the answers. But it has to be sometimes out of the box thinking. It's like, okay, put your feed in this type, in this water, and then that will detoxify you. Oh yeah, you see all those bubbles there and all the white stuff. That is your detox. Then it gets a little bit too much, right? So it needs to make right. I know. I know you've seen this, Gurdev, but it is like, okay, we need to be science-based. It needs to really make sense from a scientific perspective. So for the audience listening, out of the box thinking is perfectly fine. It just needs to make sense. Mm-hmm. And obviously you don't know, the audience, the prostate cancer thriver, which is what I call you don't know if it makes sense. And it has to be a little bit more than a feel good. So going to the right people, going to the experts is where you're going to get the information that you're looking for. The other thing I'll say is this as it relates to studies. I love science, and I'm in PubMed, every day looking at probably about 10 papers a day. I mean, I think it's very important. But we also have to know that, the research, as you said, retrospective studies, I think there's some value there.
So
it's not the end all be all. I get it. Prospective studies better. That doesn't mean retrospective studies, which means for the audience looking back and looking at the results that from that you have from, not looking forward. Let's start now and see what happens if this person does hyperthermia versus people who don't or whatever. We're looking back and looking at their data. I think there's value there. I think particularly if it's not a questionnaire thing. You're not asking them to, hey, what did you eat 2 years? For the last 2 years, did you eat enough? Like these nutrition and diet type of retrospective studies. This is like, look, this is what our data is showing. We're collecting our data. So I think there's value there. And lastly, I'll say, research and scientists and science and the companies and the publications that accept abstracts and to be published, they're looking for single modalities so that it doesn't kind of murky up the evidence. So we want to know what's the one thing that's working. To me, that's a shortcoming of science. That's the one shortcoming. Cancer is very complicated. It's multifactorial. Look what you said. Hey, we're hitting the M1 phase and the S phase. And if we do both, we're hitting this phase and that phase. I want to hit all the phases. I want to hit all the pathways. So let's study that. Let's study all these modalities together and see, because together, why is there ADT with radiation? Well, because it seems to be better both than just one. Right. So same thing with hyperthermia radiation or this nutrient and things like that. So I'm kind of on a soapbox a little bit here, but you get my point. I think that we just need to look at it differently, and the audience needs to understand. Look, it's not black and white, and appropriate science-based, out-of-the-box thinking, done right, going to the right experts, can be meaningful. Your thoughts on my rant?
Well, it's a great rant. I mean, I have a million thoughts. First, let me say I agree with you, Geo, 100%. I do not believe in a silver bullet. I believe in a silver shotgun. And I think if you want to treat cancer, you have to come at it from multiple angles. Look, just think of the hallmarks. There's inflammation, there's angiogenesis,
Mitochondria,
there's mitochondrial dysregulation, there's evading the immune system. There's all these things, and if you just come at it with one, it doesn't happen. And as a naturopathic oncologist like you, we're not doing one thing. This is how you should eat. This is how you should live. These are some targeted nutrients. These are some, there's all these therapies that we're suggesting to our patients, which is why it makes it so difficult to publish our data, because as you said, most scientists want a single variable that they can point their finger at. And what we do is called real world evidence. Like it's called real world evidence. And you know what I'll say to you, Geo? The fact of the matter is every study is real world, because if you have a population of men in a study on this ADT agent, can you actually control each and every subject in that study for what they do or don't do with their diet and their lifestyle and what pharmaceutical drugs they're taking? Right. And everybody's on a different cocktail. And how can you say there's only one variable that's being assessed? It's not real. So in our population, our patients are doing many things, which is, I think, what gives us the results we get. I will say to you that we have data now 14 years that every patient with a stage 4 malignancy, the 10 most common stage 4 malignancies that we have treated, all have a significant improvement to their overall survival when compared to SEER. Like a doubling or more. In the case of colorectal cancer, I told you we've just published this study, 184 patients or whatever it is. And our patients that do hyperthermia and our naturopathic treatment approach, when compared to standard of care, there's more than a doubling of a survival expectation. And I believe it's because of this multifactorial whole person approach to their care.
Oh, I love it. Thank you. Dr. Gurdev Parmar, thank you so much for being on. This was, I think my audience, they've been asking, hey, bring an expert on hyperthermia. When are you going to talk about hyperthermia? Well, here you go. Here you have it. So I thank you for taking time for being on and really educating me and the rest of us here. Final words, and how can people find you and or your clinic?
So first of all, Geo, thanks again for having me on. Sure. It's long overdue. If you ever want me back, I'll be happy to come back. This has been enjoyable. People can find me through my clinic, Integrated Health Clinic, so integratedhealthclinic.com, or my educational institute, the Integrative Oncology Institute.ca. And there you can see what I'm up to and what I'm busy doing. And I'd be more than happy to have another hangout with you, Geo.
Hey, be careful what you ask for.
Mm-hmm.
Thanks again. So much, thanks for being on. Hey, everyone. Thank you for tuning in. And I really appreciate you. First of all, I appreciate you coming on and spreading the word on the Dr. Geo Prostate Podcast. Look, there's nothing like it that I've seen. And I think you get a lot of value here from, I get only the best of the best in each respective field. And I think that when you're looking, the bottom line is you need good information, right? You need to get adequate quality information from experts. And that's what we try to do here. And so I appreciate you. Much love to you all. And I'll see you next time. Stay tuned. Dr. Geo here, signing off. Thanks for tuning in to this week's episode of the Dr. Geo Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.